All right, let's dive into some CNUR 202 stuff today. Specifically, that October 29th lecture on cardiovascular meds
Oh, yeah.
for hypertension and heart failure.
Lots of meds.
I know. It felt like a fire hose of information.
Yay.
ACE inhibitors, ARBs, calcium channel blockers,
Mm-hmm.
and that's just the beginning.
Yeah, it's a lot to take in.
So today we're going to break it all down.
Absolutely.
We're going beyond just what each drug is, We're talking mechanisms of action, indication,
Side effects.
but
Yeah.
most importantly, what you as a future nurse
Right.
need to know to actually give these meds safely.
Yeah. The need to knows.
So before we even think about giving any of these,
Right.
your notes are really big on getting a thorough patient history and physical exam.
Yeah, absolutely.
Seems obvious, but why is it so important here?
Well, you have to think about it. It's like you're a detective, right? You're trying to uncover these potential problems.
Okay.
Interactions, things that could go wrong.
Okay, so what? Give me some examples.
Okay, so your notes mention licorice,
Uh-huh.
ginseng,
Okay.
St. John's wort,
Oh, yeah.
even everyday things, decongestants, NSAIDs.
Right.
These can all mess with these meds
Really? In what way?
in surprising ways. I mean, licorice, it can actually increase blood pressure.
Mm.
So it's working directly against those antihypertensives.
Oh, wow.
Ginseng, it can reduce their effectiveness. And St. John's wort,
Yeah.
oh man, it interacts with so many meds.
Yeah.
It speeds up how fast they break down in the liver.
Oh.
So they might not work as well.
So it's like they're all fighting each other
Yeah, it's like a battle in the body.
in the patient system.
Exactly.
Okay, and what about those common OTC meds?
Like decongestants,
Yes.
pseudoephedrine, that kind of thing.
Mhm.
Blood pressure spike.
Really?
Yeah, and NSAIDs, like ibuprofen,
Yeah.
they can make those antihypertensives less effective.
Huh.
And even high doses of aspirin can be a problem.
Wow.
It's all about understanding these conflicts before they become a real issue.
It's like a minefield. Okay, what about prescription interactions?
Oh, yeah, there are a bunch of those.
Anything in particular we should look out for?
Definitely corticosteroids, oral contraceptives, some antidepressants.
Mm.
Those can all raise blood pressure
Right.
or interact with these meds in dangerous ways.
Oh, wow.
So, getting that initial assessment,
Right.
it's not just routine, it's super important.
That's like the foundation.
Exactly. And speaking of tailoring treatment,
Yeah.
there's that start low and go slow principle,
Oh, right. Especially with older adults.
especially with older adults. Yeah.
Okay, remind me why that's so important.
Well, think about it.
Yeah.
As we get older, our bodies process medications differently.
Uh-huh.
Our kidneys might not be as efficient.
Right.
Our metabolism slows down.
Right.
So by starting low and increasing gradually, we're minimizing those side effects.
Makes sense.
And, we can really fine tune that dosage. Yeah.
Personalized medicine, basically.
Okay, so it's not one size fits all.
Nope, not at
You
all.
got to really think about the individual patient.
Exactly. Now, before we move on to specific drug classes,
Okay.
remember that bit about IV antihypertensives
No, right?
and ECG monitoring?
Right.
That's like a safety must-have.
Yeah, because those IV meds act so fast, right?
Exactly.
You've really got to keep a close eye on things.
Yeah, you need to catch those potential problems early.
So that ECG is like our early warning system.
Exactly. Safety first, always.
Always. Okay. With those general principles in mind,
Yeah.
let's dive into some specifics.
Okay, sounds good.
Starting with the ever-popular beta blockers.
Beta blocker.
Or, as I like to remember them, the LULs.
Right, the lulls.
You got that awesome mnemonic B1 equals 1 heart.
Oh, yeah, that's a classic.
Yeah.
It helps us remember that those cardioselective beta blockers,
Uh-huh.
they mainly target those beta-1 receptors,
Right.
which are found in the heart.
Okay, but hang on a second.
There are also non-cardioselective beta blockers, right?
Right.
What's the difference and why should we care?
That's a key point. So cardioselective beta blockers,
Oh, yeah.
they zero in on the heart,
Oh, yeah.
reducing heart rate, blood pressure, and oxygen demand.
Mm-hmm.
But non-cardioselective beta blockers,
Yeah.
they block both beta-1 receptors in the heart
Oh?
and beta-2 receptors found in the lungs and blood vessels.
So that's where it could get tricky for people with breathing problems.
Exactly. Blocking those beta-2 receptors in the lungs can cause wheezing and trouble breathing,
Right.
especially in people with asthma or COPD.
Okay, so beta blockers, they're all about blocking those beta receptors.
Right.
But how does that translate to those cardioprotective effects?
Okay, so imagine this.
Yeah.
Beta 1 receptors, they're like little gas pedals in the heart.
Okay.
When they get stimulated, they rev up the heart rate
Mm-hmm.
and make those contractions stronger.
Mm-hmm.
Beta blockers are like brakes,
Okay.
slowing things down, reducing that workload on the heart.
So it's like giving the heart a break.
Exactly. And because they reduce that workload, they decrease the heart's need for oxygen,
Oh, okay.
which is super important in things like angina,
Right.
where the heart muscle isn't getting enough oxygen.
Right. And that causes that chest pain.
Exactly.
So it's amazing how one class of drugs
Yeah.
can have so many applications. Your notes mention they're used for
Oh, yeah.
all sorts of things, not just heart conditions.
Absolutely. They can be used to treat anxiety, prevent migraines.
Whoa, really? Anxiety and migraines.
Yeah.
That's fascinating. How does that work?
So for anxiety, they block those physical symptoms.
Uh-huh.
You know, like that racing heart, trembling, sweating.
Right. The fight or flight response.
Exactly. And with migraines, they think it's because they prevent blood vessel dilation in the brain, which causes that throbbing pain.
Oh, wow. Okay, but as with any powerful medication,
Right.
there are contraindications. Right.
Definitely.
Your notes specifically mention severe pulmonary disease and acute heart failure.
Yes.
Why are those red flags for beta blockers?
Well, because in those cases, the heart is already struggling, you know.
Okay.
So by blocking those beta receptors,
Yeah.
it can actually make things worse
Oh.
because it makes it even harder for the heart to do its job.
So you gotta choose the right tool for the job.
Exactly.
All right, speaking of potential pitfalls, let's talk side effects.
Okay, sure.
Hit me with them. What should we be watching out for?
So since they work mainly on the heart,
Yeah.
most of the side effects are, you know, cardiovascular related.
Okay.
Bradycardia, hypertension, fatigue, those are all common.
Mm-hmm.
And it makes sense considering how they work.
And those non-cardio selective ones.
Yeah, those are the ones to be extra careful with.
Especially those respiratory problems, right?
Oh, absolutely. Wheezing, breathing problems,
Right.
even bronchospasms.
Wow.
Those are serious concerns for anyone with asthma or COPD.
Yeah.
Again, it comes back to that thorough assessment, making sure you have the full picture.
A full story.
Yeah, before you choose the medication.
Okay, so let's say I'm about to give a beta blocker.
Okay.
What's my nursing checklist? What are the absolute must-dos?
Right. Think of this as your safety net
Okay.
to ensure the best outcome for your patient.
Got it.
First, confirm the indication,
Okay.
check for allergies, and thoroughly assess for any respiratory conditions.
So check the why, the whoops, and the wheeze factor.
Exactly.
Vitals.
Okay, gotta get those vitals.
Yeah. Check them before A&D after you give the med.
Right.
Pay close attention to the heart rate and blood pressure.
Mm-hmm.
Your notes highlight some specific actions to take if that heart rate dips below 60
Okay.
or the systolic blood pressure falls below 100.
So if the heart rate is too slow
Yeah.
or the blood pressure is too low,
Mm-hmm.
we hold the medication and call the doctor.
Exactly.
Yeah.
You're the patient's advocate.
Right.
It's your job to keep him safe.
Okay.
Don't forget about electrolytes. Oh, right.
Especially potassium.
Okay.
Imbalances can make those side effects worse.
Right.
And because beta blockers can affect fluid balance,
Yeah.
keep an eye on those daily weights too.
Okay.
A sudden gain of 2 kilograms or more,
Uh-oh.
that's a red flag.
That's a lot to keep in mind.
It is, but that's what makes nursing so challenging and
Yeah.
rewarding.
Right. You're constantly thinking, observing,
Mm-hmm.
and using your knowledge to make decisions that really matter.
Exactly. You're making a difference.
Okay. Now that we've got the basics of beta blockers down,
Yeah.
let's move on to another big one.
Okay, what's next?
ACE inhibitors,
ACE inhibitors.
also known as the Laprils.
The Laprils.
I'll be honest, I always found their mechanism of action kind of intimidating.
Yeah, it can seem complicated.
All that angiotensin, renin, aldosterone.
But it's actually a pretty cool story.
Okay, walk me through it.
So it all starts with renin,
Okay.
an enzyme released by the kidneys. Renin converts this protein called angiotensinogen
Angiotensin.
into angiotensin I.
Okay.
Then ACE, or angiotensin converting enzyme,
Right.
it transforms angiotensin I into angiotensin II.
Okay, so renin starts it off, ACE takes over, and we end up with angiotensin II.
Good bit.
So what's so special about this angiotensin II?
Well, it's the troublemaker in this story.
Okay.
It's a powerful vasoconstrictor.
Maybe.
It tightens those blood vessels and increases blood pressure.
Okay.
And it also triggers the release of aldosterone.
Aldosterone.
Which is a hormone that makes the body hold on to more sodium and water.
Oh, wow.
Driving up that blood pressure even further.
So it's a double whammy.
Yeah, it's a 1-2 punch.
No wonder it's a target for treatment.
Exactly. And that's where those ACE inhibitors come in.
Okay.
They block ACE.
Right.
Preventing the formation of angiotensin II.
Oh, so they're stopping it at the source.
Exactly. They break the chain.
Love it.
And by reducing angiotensin II, they also decrease aldosterone secretion.
Okay.
Less sodium and water retention.
So lower volume equals lower pressure.
Exactly. It's all connected.
They're like puppet masters, pulling the strings to control blood pressure.
I like that.
But their talents don't stop there.
Oh, no, they do much more.
They also have renal protective effects.
Especially for those with diabetes.
Wait, renal protective. So they protect the kidneys.
That's right.
How?
High blood pressure puts a lot of stress on the kidneys.
Right.
Over time, that can lead to diabetic nephropathy.
Oh, yeah.
Which is a serious complication. ACE inhibitors, by lowering blood pressure, they help protect those kidneys.
Okay.
And slow down the progression of that condition.
So they're like a 2-for-1 deal.
Exactly. Lowering blood pressure and de-protecting the kidneys.
Which is why they're so often used for people with both hypertension and diabetes.
Absolutely.
But no medication is perfect.
You're right about that.
What about side effects?
Well, they do have that one notorious side effect.
Oh, you mean the infamous ACE inhibitor cough?
That's the one.
Everyone talks about that.
Yeah, it's pretty common, unfortunately, and it can be pretty persistent.
Why does it happen?
They think it's caused by this buildup of bradykinin.
Bradykinin.
Yeah, a substance normally broken down by ACE.
Oh, so by blocking ACE, they accidentally cause a bradykinin party in the lungs.
That's the idea.
Triggering the cough.
Exactly.
Okay, but the good news is...
Yeah.
It goes away when you stop the medication.
Usually.
But there's another side effect, right?
There is, a more serious one.
Angioedema.
That's the one.
And that sounds scary.
It can be.
What is it exactly?
It's this rare.
Yeah.
But potentially life-threatening allergic reaction.
Oh, wow.
It causes swelling
in
the deeper layers of the skin, often around the face, lips, and tongue.
Oh, no.
Yeah, and in severe cases, it can even affect the throat.
Oh, wow, that's dangerous.
Yeah, it can cause difficulty breathing.
That's a medical emergency.
Definitely.
Okay, so that definitely goes on the things to avoid list.
For sure.
When would we completely avoid ACE inhibitors?
Well, the obvious one is if someone's allergic to them.
Right.
And because of that angioedema risk, we avoid them in people with a history of angioedema. Pregnancy and lactation are also no-goes.
Right.
They can be harmful to the fetus or a nursing infant.
Makes sense. Any other red flags?
Yeah, bilateral renal artery stenosis.
What's that?
So that's when the arteries that supply blood to the kidneys, they're narrowed.
Right.
ACE inhibitors can actually make that worse by further reducing blood flow.
Ah, so it's like a domino effect.
Exactly.
Okay, so allergies, history of angioedema, pregnancy, lactation, and bilateral renal artery stenosis.
All big reasons to choose a different medication.
Right, and of course, like with any medication, you got to monitor for those side effects.
Absolutely, monitoring is key.
Speaking of other medications, let's talk about ARBs.
ARBs, okay.
Angiotensin II receptor blockers.
Right.
They're like the cousins of ACE inhibitors, right?
Yeah, you could say that.
They both target that RAAO system, but they do it in slightly different ways.
Exactly. It's like they're working on opposite ends of the problem.
Okay.
So ACE inhibitors, they prevent angiotensin II from forming ARBs. They let it form, but they block its effects by preventing it from binding to its receptors.
Ah, so they both want to control angiotensin II, but they're using different strategies.
They have different approaches.
Okay, I like that.
Right. It's like ACE inhibitors stop the troublemaker from being born.
Okay.
And ARBs lock him out of his house so he can't cause any trouble.
I love that analogy. So are ARBs the go-to then when a patient can't tolerate that ACE inhibitor cough?
Often, yes.
Okay.
But they have their own side effects too, of course.
Of course. Like what?
Dizziness, headache.
Okay.
And in rare cases, angioedema. It's much less common with ARBs than with ACE inhibitors, though.
Okay, good to know.
Yeah.
So we've got these two players on the field, both trying to control blood pressure through the RAAS.
Right.
How do we decide which one is right for a particular patient?
That's a great question, and it really depends on the individual patient.
Yeah.
You know, their medical history, other meds they're taking,
Right.
their tolerance for side effects.
Okay.
If someone gets that persistent cough with an ACE inhibitor,
Yeah.
then an ARB might be a better choice.
It's about picking the right tool from the toolbox.
Exactly. Each medication has its own strengths and weaknesses.
Okay, so let's do a quick comparison.
Okay, sounds good.
ACE inhibitors versus ARBs.
Okay.
What are the main takeaways?
Well, they're both effective for treating hypertension and managing heart failure.
Mm-hmm.
They both offer renal protection.
Especially in those with diabetes?
Exactly. And they both work on the RAAS.
Right, in different ways though.
Right, different ways.
So those are the similarities. Now what about the differences?
All right, so the biggest one is that cough.
Right.
ACE inhibitors are much more likely to cause it.
Right.
Then there's the risk of hyperkalemia.
High potassium.
Yep, high potassium. ACE inhibitors have a slightly higher risk of that.
Mm-hmm.
And finally, studies have shown that ARBs
Yeah.
might actually be better in the long run.
Oh, really?
Yeah, they might offer better cardio protection.
Okay.
Lower mortality rates after a heart attack.
Wow, that's a big difference.
It is, and it shows that, you know,
Yeah.
it's not just about choosing between two similar drugs.
Right.
It's about understanding the subtle but important differences.
Right, because it could really impact the patient's outcome.
Absolutely. It all comes back to personalized medicine.
Absolutely.
Right.
Okay, speaking of personalized medicine,
Okay.
there's this newer class of drugs
Oh, yeah.
that combines ARBs with another medication,
Mm-hmm.
neprilysin inhibitors.
Right.
And those are called ARNIs.
You
Right?
got it. ARNIs.
Angiotensin receptor neprilysin inhibitors.
Yeah, that's them.
They're fairly new
Yeah, relatively new.
for heart failure treatment.
Mm-hmm.
So what are these neprilysin inhibitors all about?
Okay, so neprilysin is an enzyme that
Right.
breaks down natriuretic peptides.
Natriuretic peptide.
Yeah, and these peptides,
Yeah.
they're like little superheroes.
Okay.
They help regulate blood pressure and fluid balance.
Hmm.
So by inhibiting neprilysin,
Okay.
we actually increase those peptides.
So it's like boosting their power.
Exactly.
Okay.
So they promote vasodilation
Okay.
and they help get rid of excess fluids.
So the double whammy of good stuff.
Yeah. And while that's happening, the ARB part of the drug is blocking those angiotensin II receptors.
So they're hitting the problem from two different angles.
Exactly. That's why ARNIs are used specifically for chronic heart failure with reduced ejection fraction,
Okay.
or HFrEF.
HFRE.
Yeah, it's a condition where the heart
Okay.
isn't pumping out enough blood with each beat, and ARNIs can really improve that.
Wow. So it sounds like they're game changers for heart failure.
They can be, yeah, but of course, there are things to watch out for.
Of course. Like what?
Like all meds, they have potential side effects,
Mm.
hypotension, hyperkalemia,
Okay.
and rarely angioedema.
Oh, right.
And because they interact with the RAAS,
Yeah.
there are some important contraindications.
Oh, like what?
Pregnancy, lactation, a history of angioedema.
Okay.
And you have to wait 36 hours after stopping ACE inhibitors before you can start ARNIs.
36 hours. That's very specific. Why?
It's a safety precaution
Okay.
to prevent those interactions.
Hmm.
Both ACE inhibitors and ARNIs work on the RAS, and
Oh.
switching between them too quickly
Yeah.
can throw things off balance.
Got it. So ARNs are powerful,
Yeah,
but they come with their own considerations.
just like all medications.
Okay, we've talked about beta blockers,
Mm-hmm.
ACE inhibitors, ARBs, and ARNIs.
The whole family.
It is a
Yeah.
whole family of medications
Right, each with its own personality.
and its own quirks.
Exactly. And just like with any family, you need to understand how they interact
Right.
to create an effective treatment plan.
Okay, ready to meet another member of the family?
I am. Who's next?
Let's talk about calcium channel blockers.
Calcium channel blockers.
I remember from physiology
Yeah,
that calcium is super important for muscle contraction.
it is.
So how does that relate to these medications?
Good question. It all boils down to those smooth muscles that line our blood vessels.
Okay.
When calcium gets into those muscle cells, it
Yeah.
makes them contract,
Okay.
which narrows the vessels.
So calcium's like the squeeze signal.
Yeah, exactly.
Okay.
And calcium channel blockers,
Yeah.
they block that calcium from getting it,
Right.
preventing those muscles from contracting.
So they cut off the squeeze signal.
Exactly.
So does that mean they only affect blood vessels?
Well, they do lower blood pressure that way.
Right.
But they have effects on the heart itself, too. Oh, okay.
They can slow the heart rate
Okay.
and reduce how forcefully it contracts.
So they're multitaskers.
They are, tackling both blood pressure and heart function.
That's awesome. But are there any downsides?
Well, of course, like any medication,
Right?
there are potential side effects.
Okay, like what?
Some common ones are peripheral edema,
Okay.
headache, flushing, palpitations, constipation.
So mostly minor stuff.
Usually, yeah.
Anything more serious to be aware of?
Well, there are a couple of things.
Okay.
Heart failure and excessive hypotension.
Wait, heart failure. I thought these were supposed to help the heart.
They can be beneficial for certain heart conditions,
Right.
like angina, for example,
Mm-hmm.
but they can also weaken the heart's pumping ability.
Oh,
Because
yeah.
it's obviously a concern if the heart's already weak.
So again, it's about finding that balance.
Exactly. The right dose for the right patient.
And careful monitoring.
Always.
Okay, so what are our nursing priorities when it comes to calcium channel blockers? All right, so before you give the medication,
Yeah.
you need to assess those vital signs,
Okay.
especially their pulse and blood pressure.
Mm-hmm.
And then you need to monitor those same things
Yeah.
after you give the med.
Right, to see how they're responding.
Exactly. You got to be on the lookout for signs of heart failure.
Right. Okay, like what?
Shortness of breath, fatigue,
Okay.
swelling in the legs and feet.
Right.
Those are all red flags.
Got it. And what about fluid balance?
Super important.
Okay.
You'll be monitoring their intake and output
Mm-hmm.
and watching for any sudden weight gain.
Right, which could mean fluid retention,
Exactly. You're looking for those subtle clues.
like a detective.
Exactly.
Well, we've covered beta blockers,
Mm-hmm.
ACE inhibitors,
Mm.
ARBs, ARNIs,
Right.
and now calcium channel blockers.
It's a lot.
It's like a whole symphony of medications
That's a great way to put it.
working together to keep the cardiovascular system healthy.
Yeah, like an orchestra.
But the symphony isn't over yet.
Ooh, what else is there?
There's another important class we need to talk about.
Okay.
Diuretics.
Diuretics, the fluid manipulator.
I'm ready to dive into that world.
All right, let's do it.
So they're all about making people pee, right?
Well, they are known for that.
Right.
But their role in hypertension and heart failure,
Yeah.
it goes way beyond that.
Okay, tell me more about these fluid flushers.
So diuretics, they're a diverse group of meds,
Okay.
but they have a simple goal.
What's that?
They remove excess sodium and water from the body.
Okay.
They're like the body's plumbing system.
They're like a...
They flush out the excess.
So by reducing fluid volume, they lower blood pressure
Exactly.
and take some of that workload off the heart.
Right.
But I know there's more to it than just peeing more.
There is.
Different diuretics work in different ways, right?
Yeah, you're right. We categorize them based on how they work
Okay.
and where they act in the kidneys.
All right, so walk me through the diuretic family tree.
Okay.
What are the main branches?
Well, we have loop diuretics,
Okay.
potassium-sparing diuretics,
Mm-hmm.
thiazide diuretics,
Okay.
and thiazide-like diuretics.
Got it. So let's start with the heavy hitters, the loop diuretics.
The loop diuretics. Sorry.
My notes mention furosemide or Lasix as the MVP of that group.
Lasix, it's definitely a star player.
So how does it work?
It works by inhibiting the reabsorption of sodium and chloride.
Okay.
It works by inhibiting the reabsorption of sodium and chloride
Okay.
in the loop of Henle.
The loop of Henle.
Yeah, it's a specific part of the kidney's nephron.
Right, the nephron. That's the functional unit of the kidney.
Exactly. So basically, it's messing with the kidney's ability to hold on to sodium and chloride,
Okay.
sending them out with the urine instead.
So more sodium and chloride in the urine means...
More water in the urine.
Right, because water follows sodium.
It does. So you get increased urine output
Okay.
and a reduction in fluid volume.
So it's like manipulating those electrolytes to control fluid balance.
Exactly. It's all connected.
So when would we use a loop diuretic like Lasix?
Well, they're known for their rapid onset
Okay.
and short duration of action. They're like the emergency responders of the diuretic world.
Okay, I like that analogy.
Right. Ideal for when you need to remove fluid quickly.
So like in an emergency situation.
Exactly. They're often used for edema.
Edema.
So swelling, right? Swelling associated with heart failure,
Okay.
liver disease, kidney disease.
So situations where you need to act fast.
Exactly. But with great power comes great responsibility, right?
Of course. What are the risks?
Well, one of the biggest concerns is electrolyte disturbances,
Oh.
particularly hypokalemia,
Low potassium.
low potassium. Yeah, it's a big deal.
Why is that?
Potassium, it's crucial for muscle function,
Okay.
including the muscles that control our heartbeat.
Oh, right.
So low potassium.
Yeah.
It can lead to arrhythmias.
irregular heart rhythms.
Exactly, which can be really dangerous.
So it's not just about fluid balance.
No.
It's about those electrolytes, too.
It's all connected.
Okay, and loop diuretics can cause a lot of fluid loss.
Right.
So what else do we need to watch out for?
Dehydration and hypotension.
Low blood pressure.
Yeah, those are definitely concerns.
Okay, anything else specific to loop diuretics?
There's one more thing.
Okay.
Ototoxicity.
Ototoxicity, what's that?
It means damage to the inner ear.
The ear. Wow, I wouldn't have expected that.
Yeah, it's not super common.
Okay.
But it can happen.
Oh.
They think it has something to do with how the drug affects certain structures in the inner ear. It can cause tinnitus.
Ringing in the ears?
Yep, and even hearing loss.
Wow, that's serious.
It is, but thankfully it's pretty rare.
Okay, that's good to know.
And it's more likely with high doses or if someone's on the drug for a long time.
Okay, so ear problems are a possibility.
Yeah.
But uncommon.
Usually.
So it sounds like loop diuretics are powerful.
They are.
But they require careful monitoring.
Absolutely.
All right, let's move on to their potassium-friendlier counterparts, the potassium-sparing diuretics.
The potassium protectors.
Tell me more about these gentle giants.
So, as their name suggests, they help get rid of excess fluid.
Okay.
But they hold on to potassium, making them a good choice for patients at risk for hypokalemia.
Right, because we just talked about that.
Exactly.
So which one is the most well-known?
Spironolactone or aldactone?
Aldactone, okay.
So how does it work?
Well, it blocks the action of aldosterone.
Aldosterone, remind me what that is again?
It's a hormone that promotes sodium and water retention.
Okay.
So by blocking aldosterone,
Yep.
spironolactone prevents the reabsorption of sodium and water,
Okay.
leading to more pee, but without losing potassium.
So it's like a 2-for-1 deal.
It is. Fluid control plus potassium conservation.
I like it. And because of this unique mechanism, they're often used with other diuretics, right?
That's right, like loop diuretics
Okay.
or thiazide diuretics.
To balance out those potassium wasting effects.
Exactly. It's all about teamwork. A diuretic dream team.
Uh-huh. I like that.
But even though they're potassium sparing,
Yeah.
they still have potential side effects, right?
Of course. No medication is perfect.
What are we looking out for?
Most common ones are pretty mild.
Okay.
Dizziness, headache, nausea, vomiting, diarrhea.
Okay.
But, kind of ironically,
Yeah.
the biggest concern is actually hyperkalemia.
High potassium.
High potassium, yeah.
But I thought these drugs were supposed to prevent that.
They help prevent hypokalemia,
Okay.
but they can also tip the scales too far in the other direction.
Right, because they're holding on to potassium.
Exactly.
Okay, so what do we need to be aware of?
Well, if the patient's taking other meds that increase potassium, or if they have kidney problems,
Okay.
that increases the risk.
So again, careful monitoring of those potassium levels.
Absolutely. And like with any diuretic,
Yeah.
you got to watch for dehydration and low blood pressure.
Okay, so we've got loop diuretics
The rapid responders,
and potassium-sparing diuretics.
the potassium protectors.
Now, what about thiazide diuretics?
Thiazide diuretics. Okay.
Where do they fit in?
Well, they're probably the most commonly prescribed diuretics.
Really?
Yeah, especially for hypertension.
Wow, so they're like the workhorses of the diuretic world?
Haha, I like that.
So how do they work?
They inhibit the reabsorption of sodium, chloride, and potassium.
Okay, sounds familiar.
It happens in the distal convoluted tubule.
That's another part of the nephron, right?
Exactly. Different part of the kidney.
So they're kind of like loop diuretics, but in a different location.
You could say that.
Okay, so what does that lead to?
More of those electrolytes get excreted.
With water.
Right, with water. So lower blood volume, lower blood pressure.
Okay, and like loop diuretics.
Yeah.
They can cause those electrolyte disturbances,
They can.
especially hypokalemia.
That's a big one to watch out for.
Okay, so we're back to potassium monitoring.
Always monitoring those electrolytes.
Anything else we should be aware of?
They can also cause hyponatremia.
Low sodium.
Low sodium, yep. And they can affect glucose metabolism,
Oh.
which can lead to hyperglycemia,
High blood sugar.
especially in people with diabetes.
So it's not just potassium.
Well,
We got to watch sodium and blood sugar too.
that's right. Diuretics, even though their goal is simple,
Right.
they can have a lot of effects.
That's like a ripple effect.
It is. But they're so valuable for managing fluid balance
Mm-hmm.
and blood pressure.
Okay, before we move on from diuretics,
Yeah.
what about those thiazide-like diuretics?
Thiazide-like diuretics.
Are they just thiazides with a fancy name?
Haha, they're similar to thiazides
Okay.
in how they work and their overall effects,
Mm-hmm.
but their chemical structure is slightly different.
So subtle differences.
Exactly. Examples are
Yeah.
metolazone, chlorthalidone and indocamide.
Okay, so like the thiazide siblings.
You could say that.
Offering similar benefits, but with their own little quirks.
Exactly. And just like with families.
Yeah.
You got to understand those individual quirks.
To choose the right one.
Exactly. The right diuretic for the right patient.
All right, we've explored the loop diuretics.
The rapid responder.
The potassium-sparing diuretics.
The potassium protects.
The thiazide diuretics.
Right.
And the thiazide-like diuretics.
It's a whole diuretic toolbox.
It is. And each one has its own strengths and weaknesses.
Absolutely.
So we really need to think about the patient's individual needs and those potential risks
every time
when choosing a medication.
Personalized medicine.
This has been an incredible journey through the world of cardiovascular meds.
It has. We've covered a lot of ground.
Beta blockers, ACE inhibitors, ARBs, ARNs.
Don't forget calcium channel blockers.
Oh, right. And those diuretics.
We've covered it all.
It's like a whole map of the cardiovascular medication landscape.
It is, and it's crucial information for any nurse working with hypertension or heart failure patients.
But our journey isn't over yet.
There's more.
There's one more medication we need to discuss.
Okay, what is it?
A drug with a long and interesting history in heart failure treatment.
All right, I'm intrigued.
Digoxin.
Digoxin. Classic.
It is. It's like a legend in the world of cardiovascular meds.
It's been around forever.
So tell me, what's the story behind this legendary drug?
Well, digoxin, it actually comes from the foxglove plant.
What? Really? A plant?
A plant, and it's been used medicinally since the 18th century.
Wow. That's incredible. A true veteran.
It is.
Okay, so how does it work? What's its secret weapon against heart problems?
Okay, so digoxin is a cardiac glycoside.
Cardiac glycoside.
Yeah, and its mechanism of action.
Yeah.
It's a bit complicated, but in a nutshell,
yeah,
it increases the force of the heart's contractions
okay,
by inhibiting an enzyme called sodium-potassium ATPase.
Sodium-potassium ATPase.
Yeah, it's a mouthful.
It is.
But basically, this leads to higher levels of calcium inside those heart muscle cells.
Ah, so those electrolytes are back in play.
Always.
So more calcium equals stronger contractions.
Exactly. So digoxin helps the heart pump more blood with each beat.
Okay.
Improving circulation and reducing those heart failure symptoms.
So it's like giving the heart a power boost.
Yeah, that's a good way to put it.
But it doesn't just increase the force of contractions, right?
You're right. It does more.
What else does it do?
Well, it also has what we call a negative chronotropic effect.
A negative chronotropic effect.
Yeah, it sounds kind of intimidating.
It does. What does it mean?
It just means it slows down the heart rate.
Oh, okay.
Which can be really helpful for certain arrhythmias.
Okay.
Like atrial fibrillation.
Atrial fibrillation, that's when the heart's beating too fast.
And irregularly.
Yeah, so it's calming the heart down.
Exactly, bringing some order to the chaos.
And it also has a negative dramatropic effect.
That's right.
Which means?
It slows down the conduction of those electrical impulses in the heart.
Okay.
So even more regulation of those irregular rhythms.
So it's a triple threat. Stronger contractions.
Yep.
Slower heart rate. And regulated electrical signals.
It's a pretty versatile drug.
It is. But it's not a first-line treatment for heart failure anymore, is it?
Not really, no.
Why not? If it does all that good stuff?
Well, studies haven't really shown that it helps people live longer.
Oh, interesting.
It might make them feel better.
Okay.
But it doesn't seem to impact survival.
So it's more about quality of life.
And quality of life, yeah.
I see.
And there are other meds now.
Right.
Like ACE inhibitors and beta blockers that DO seem to improve survival.
Okay, so they're the preferred choice now.
For most patients, yes.
But digoxin is still an option.
It is, but there's something we have to be really careful about.
You mean digoxin toxicity?
That's the one.
It's one of those meds with a narrow therapeutic window, right?
Exactly. The difference between a helpful dose and a harmful dose is small.
So we got to be really careful.
We do.
What are the signs of digoxin toxicity?
The earliest signs usually involve the GI system.
Okay.
Abdominal pain.
Okay.
Anorexia, nausea, vomiting.
So tummy troubles.
Yeah, those are early warning signs.
What else?
Visual disturbances can also happen.
Like what?
Seeing halos around lights.
Okay.
Blurred vision. Even changes in how they see color.
Whoa, really?
Yeah, they might start seeing yellow or green tinges.
That's wild.
It is.
Okay, so we've got tummy troubles, vision problems. Anything else?
Yeah, what about the heart?
Oh, right. What are the cardiac signs?
Well, bradycardia.
Slow heart rate.
Slow heart rate, yeah. It's a classic sign.
Okay.
And because digoxin affects the heart's electrical system, it can cause arrhythmias too.
Irregular rhythms.
Exactly.
Okay, so those are some serious red flags.
They are.
What do we do if we suspect digoxin toxicity?
First things first, hold the medication.
Okay.
And call the doctor immediately.
Stop the meds and get help.
Exactly. Time is of the essence.
So depending on how serious it is, the treatment could involve supportive care?
Right, like fixing electrolyte imbalances.
Okay.
Or even giving an antidote.
Oh, there's an antidote.
There is. It's called digoxin immune fab.
Okay.
It binds to the digoxin and helps remove it from the body.
So it's like reversing the toxicity.
It is.
But prevention is always better than cure.
Right, absolutely. So what are the key nursing interventions for digoxin?
What should we be doing to keep our patients safe?
All right, so before we even think about giving digoxin, we need a good baseline assessment.
What does that look like?
Vitals, listening to those heart sounds.
Okay.
And a baseline ECG.
So we're getting a clear picture of their heart before we give the drug.
Exactly.
Yeah.
Electrolytes, especially potassium.
Right.
Low potassium makes digoxin toxicity more likely. So we need to fix any imbalances before we start the med.
So potassium and digoxin, they're like a delicate dance.
I like that. They have to be in sync.
What about kidney function?
Oh, that's crucial too.
Okay.
Digoxin is eliminated mainly by the kidneys. So if the kidneys aren't working well, the drug can build up.
Oh, okay.
And that increases the risk of toxicity.
So we're keeping a close eye on those kidneys.
Absolutely. It's all about monitoring.
It seems like vigilance is key with all these cardiovascular meds.
You're absolutely right. They're powerful drugs.
Yeah.
With the potential for both good and bad effects.
Right.
Our job as nurses is to use our knowledge and our skills to make sure those benefits outweigh the risks.
Well, we've covered so much information today.
It's been a whirlwind.
Hypertension, heart failure, beta blockers, ACE inhibitors, ARBs,
ARNIs, calcium channel blockers, diuretics.
Even the legendary digoxin.
We've been through it all.
It's like a complete tour of the cardiovascular medication landscape.
It is. And it's a great foundation for understanding these medications.
Absolutely. And it highlights how important our nursing skills are.
Absolutely.
In giving these meds safely and effectively.
It's all connected.
But before we wrap up, I want to touch on something we've talked about a lot.
What's that?
Personalized medicine.
Ah, yes.
It seems like that's a theme with all these different drug classes.
You're right. It's not just about memorizing names and dosages. It's about seeing the whole patient.
Right.
Understanding their needs, their risks, how they respond.
It's about seeing the person behind the diagnosis.
Exactly.
It's like we're not just giving meds. We're creating a whole symphony of care.
I love that. Making sure everything's working in harmony.
For the well-being of our patients.
Beautifully said.
Well, speaking of beautiful things, I think it's time to bring this deep dive to a close.
Already. Time flies.
I know. But before we do,
yeah.
I know you have a thought-provoking question for our listener.
I do. Thinking about everything we've talked about today.
Yeah.
About all these medications.
Their mechanisms, side effects.
Yeah.
Those unique interactions.
Right.
How would you prioritize patient assessment and monitoring when giving these drugs?
That's the question.
What are the key things to focus on?
Yeah.
To keep your patients safe?
That's what I want our listeners to think about.
It's a great question. And it shows how important critical thinking is in nursing.
It's essential.
We're not just following orders.
Right.
We're using our brains to make decisions.
And make informed decisions.
That can really make a difference.
Absolutely.
So to our amazing listener, as you're studying for CNUR 202, remember, this deep dive is just the beginning.
It is. There's always more to learn.
Keep those brains buzzing. Stay curious.
Explore. Ask questions.
We'll catch you on the next adventure.
Into the world of knowledge. It really makes you think,
It does, and it highlights just how much we've covered today.
Yeah, we really have.
We've built this mental map of cardiovascular meds.
We have. All those different ways they work.
Right, like those beta blockers.
Yeah.
The heart's brakes.
That's a good one.
And then the ACE inhibitors and the ARBs.
Manipulating the RAAF. It's so clever. And then those ARNIs boosting those blood pressure regulators.
The body's own superheroes.
Right. And we can't forget about the calcium channel blockers.
Oh.
Cutting off that squeeze signal.
To those blood vessels.
And, of course, the diuretics.
The fluid flushers.
Each with its own and its own potassium considerations.
It is a lot to take in.
It is. But by understanding all of this, you're not just memorizing facts.
Right.
You're gaining the power to really help your patients.
That's the goal.
Knowing how these meds work, the benefits, the risks, it lets you be a better advocate for your patient.
Absolutely.
You can anticipate those problems.
And intervene when you need to.
It's all about connecting those dots.
Between the science and the art of nursing.
Exactly. So, to our awesome listeners out there, as you're getting ready for CNUR 202, just remember, this deep dive is just the start.
It is.
Keep learning. Keep those brains working.
Stay curious. And we'll catch you on the next adventure.
Into the world of knowledge.